Good morning, ladies and gentlemen. Good morning.
Okay, now it's coming.
My name is Joan Lebow. I'm an attorney in Chicago with Lebow, Malecki, and Tasch. I want to thank Partners Healthcare for inviting me to participate this morning as moderator of this debate. Before we get started, I'll explain some of our rules of the debate, and I'll introduce our two debaters. Our question this morning is, I hope, of profound interest to our audience. Resolved: telehealth, telemedicine, and remote monitoring. The business model is not direct reimbursement, it's bundled and global payments. We have two highly qualified, distinguished debaters here this morning. Vince Kuraitis. Vince is principal and founder of BHT, Better Health Technologies Consulting. BHT consults to companies in developing strategy, partnerships, and business models for clinical care, clinical management platforms and applications delivered in homes, workplaces, and communities. Vince has a long and distinguished career in direct provider services. His education includes an MBA in JD. He is a lawyer, as am I, from UCLA, and a Bachelor of Science degree in Business Administration from the University of Southern California. Vince is on the editorial boards of Medical Home News and the International Disease Management Alliance. He is a board member of the Clinical Groupware Collaborative. He serves on the ASTM International E31 Technical Committee on Healthcare Informatics. Vince is taking the pro position this morning. And Dr. Jasper Putlitz is president of the Robert Bosch Healthcare Company, headquartered in Palo Alto, California. Dr. Putlitz leads a Bosch subsidiary that focuses on telemedicine, headquartered in California. He was previously a partner and a member of the German Management Committee and team at McKinsey, where he worked for 12 years. At McKinsey, Dr. Putlitz was a leader in the healthcare and logistics industry sectors, as well as in the human resources and organizational function practices. Before joining McKinsey, Dr. Putlitz spent 7 years working as a physician and a researcher at hospitals in Munich, Zurich, Freiburg, and here at Harvard. So the rules of the debate. As moderator, I have total control and domination over the process. But one of the fundamental hopes of our debate this morning is that you as the audience participate fully and thoroughly in the question process. We're going to flip a coin. I'm going to flip a coin as moderator, and I'm going to, by the flip of the coin, give one of our two debaters first crack at their 5-minute opening statement, and our other debater will then follow with their opening statement. I have a series of questions which I hope are provocative to follow those opening statements, and during the course of my questions, you may not interrupt me, but you may raise your hand and encourage our debaters to follow on with your own questions during the course of the debate. Before, however, we start, I want to make certain that we're all on the same page, as it were, with respect to nomenclature involved in our debate question and resolution. What is bundled payment? What is it as a concept? It's a concept that involves a fixed dollar for the episode of care involved. It's a methodology that's widely used, of course, as most of you know, in the Medicare reimbursement method currently in place. The focus of a bundled payment is almost always an inpatient episode. It begins a day or two prior to admission and can go out as many as 90 days post-discharge. The focus of a bundled payment is the episode of care. It's a clinical focus. and it's a risk transfer methodology for reimbursement purposes. Almost always, a bundled payment is risk adjusted. It's adjusted because it's understood that various levels of patient acuity increase or decrease the risk associated with that patient's care, the clinical risk and the financial risk. What is global payment? Well, some of you are old enough to remember that we had a system of reimbursement for a long time in our country that was a capitated form of reimbursement, and many people associate the term global payments with capitation. It has a risk transfer element in common with the concept of bundled payment. It's a fixed dollar form of reimbursement. It covers a period of time as opposed to a particular episode of care. It covers a period of time for a particular patient. So it's patient-focused as opposed to clinically or service-focused. It does completely transfer risk, financial risk and clinical risk, for a particular patient to either a set of providers or a set of providers and a payer. What is fee-for-service? Fee-for-service is piecework. And fee-for-service is the kind of reimbursement system that dominates the healthcare landscape in our current reimbursement methods. So, I'm going to flip a coin. Heads? Heads, call it please, doctor. Heads? Very good. Dr. Putlitz will begin the opening of our debate.
Well, thank you very much. I'm very happy to be here this morning. When I got invited to this debate, I thought, well, maybe that's not such a great gift, actually, to be in charge of the disagree position here, because didn't you want to do a show of hands here?
Thank you for reminding me.
So,
the only way that we're going to judge the effectiveness of our debaters is by polling our audience before and after the debate occurs. So a show of hands, and let me restate our resolution. Telehealth, telemedicine, and remote monitoring. Resolved. The business model for telehealth, telemedicine, and remote monitoring is not direct reimbursement or fee-for-service. It's bundled and global payments. Agree or disagree? If you agree, please raise your hand. Well, I'm surprised.
See, that's what I expected. So, and so that's why I also thought, well, maybe it's not such a great thing to be in the disagree position here, because, quite frankly, standing here as a representative of a company that's very active in telehealth and remote patient monitoring and so on, you always wonder, how do you get this adopted, So how is this actually going to make a difference in this country's healthcare system? And then, it's easy to jump to conclusions around bundled or global payments or alternative payment schemes that actually are, going to change the landscape fundamentally, and all of a sudden, telehealth and remote patient monitoring gets adopted, with mechanisms such as bundled payments or global payments. And, so I thought about it myself this way, until I really started to think twice. And so what I'd like to do today is also make a very strong point and a very strong case for fee-for-service. And that's not because I'm a former medical doctor active in practice. It is out of a true conviction that fee-for-service is probably going to play a very, very important role in adoption of telehealth and remote patient monitoring, and quite frankly also for other technologies that are going to be representing innovations in healthcare provision. Why? Well, let me just give you a couple or maybe three arguments. Now, first, if you really think about what telehealth and remote patient monitoring is, you could think about it as, pure vital sign monitoring, and that's going to create a lot of information. It's going to be very interesting. But is that going to make any difference in care provision? Is that going to make any difference in terms of cost? Probably not. What you really have to do, and actually some of the studies that have been undertaken using the systems provided by Bosch show, is you have to really change knowledge and behavior of patients and patient populations, and you have to do this in a very effective and also sustainable way. So in essence, remote patient monitoring and telehealth are about care redesign. And care redesign has a hard time to happen with bundled payments. I would hold care redesign will happen mostly if there is a real incentive to do it, and that requires a clear and explicit code, and therefore I believe that actually requires a fee-for-service scheme. Second point, effective adoption requires standards. If you think about the telehealth and remote patient monitoring industry, I think we are having probably one startup per week at the moment, or maybe even per day. I don't know, but sometimes I think it's a high rate, really. The industry, however, is in its infancy. The market is in its infancy. We're talking about a market here, maybe 100, maybe 200 million in this country. That's not big. And the whole industry has actually not created any standards at this point. And there are a lot of things out there that are very undefined, unstandardized, and it's unclear what it really would do to the care of our patients. And so my second point is really, instead of creating information, you need intervention, really. And intervention will only come about if you have a certain standard. So if you want to invest into intervention and outcomes, you will need some form of direct reimbursement. And that's my second point, why I think that fee-for-service is actually going to play a very relevant role in the future as well. And my third point is around, the really highly fragmented healthcare provision landscape, not only in this country, but also in other countries. We have a lot of small entities. We have a highly fragmented landscape in terms of hospitals, of providers, of physicians. So in a bundled payment scenario, would they be able to afford the upfront investment? Can they really control the continuum of care, which in many ways is actually not a continuum? I think that's a theoretical concept, really, if you think about it, So these episodic bundled payments actually will have to coordinate a lot of different providers with very different incentives. How would that work? Can that actually work? Do we have evidence at this point that it works? Think about also the average level of understanding around the economics of healthcare provision in our providers. If you did a bundled payment readiness assessment for our providers in this country, what would the average result be? Even large systems probably would have some issues here. So I think fee-for-service is here for a long, long time. Even in the future, it will be here. It's going to be very relevant. If you really want adoption of telehealth and remote patient monitoring, I'm just assuming that all of us in the room want this, and want this in a much more relevant and much bigger way than what we have today, then it's not about bundled and global payments. It's going to be about fee-for-service and direct reimbursement. Thank you.
Vince Kuraitis.
Thanks, Joan. September 24th, 1955. After having had a lunch of hamburger and raw Bermuda onion and a dinner of roast lamb, President Dwight Eisenhower believes he is experiencing indigestion. It goes on, and after midnight, his wife drives him to Fitzsimmons Veterans Hospital, at which point he is diagnosed with a myocardial infarction, a heart attack. His team of 4 doctors care for him, and 7 weeks later, President Eisenhower is discharged. This prefatory story sets the stage for 4 points I would like to make during this introduction. Number 1 is care coordination is a new need for a new healthcare system that we are building. Number 2, fee-for-service payment is the problem, not the solution. Third, there are many flavors of the terminology around bundled global payments. I'll try and simplify these for you, but they're all a middle ground. And fourth, we are going to need transition strategies in this path. We're not going to go from fee-for-service to all the risk being shifted to providers overnight. So let me go back to each of those points. Number one, care coordination is a new need in a new healthcare system. In the old system, go back to the year 1900, life expectancy of the average American was 46 years. We built a healthcare system designed for acute care. It was centralized. You went to the hospital, you went to the doctor. The lengths of stay were long. Again, using President Eisenhower's example, he spent 7 weeks in the hospital. And the model that we built was one of the hospital as the doctor's workshop. President Eisenhower's team of 4 doctors did their care coordination in the hospital itself, at the patient bedside, in the hallways, in the cafeteria, in the doctor's lounge. His primary care physicians did all that care coordination right there in the facility. The new system that we're building, our life expectancy in the U.S. is now 80. And as a result of 30 extra years of life expectancy, we need not an acute care system, but a system that is designed to deal with chronic conditions. Not the model of go to the hospital, go to the doctor, we fix you up and we send you home, but the model of you have a condition that you're going to have to manage for the rest of your life, and we will help you with that, as opposed to it's over and it's done with. Lengths of stay, very short. Today, if you had a heart attack, chances are you would spend about 4, perhaps as few as 3 days in the hospital. And finally, the model of hospital as doctor's workshop has greatly broken down. No longer is it the case where hospitals and doctors have this symbiotic relationship. They compete a lot. In fact, there's many reasons. Example, you're likely to be transferred to a hospitalist. You're not going to have the same team of doctors caring for you in the hospital and outside of the hospital. Number 2, fee-for-service payment is the problem, not the solution. I'm sure we'll get into this into a little bit more depth. I just will say I feel sorry for my colleague, Dr. Putlitz, who has to defend the face of evil in this debate. Someone's got to do it. Okay. Number 3, there are many middle ground options here. Let me frame this for you. On one extreme, we've got fee-for-service payments. The more you do, the more tests, the more procedures, the more admissions, the more you get paid. The risk there is incentivizing overutilization. Okay, at the other extreme, as Joan mentioned, we have pure capitation, where all of the money is handed over to the providers with a pot of money. You get $250 per patient per month. You take care of all of their health care problems. The risk there is one of underutilization. So we have this broad continuum. All of the options that we are talking about today and others really are in this middle area where what we are trying to build is a system where we have not overutilization nor underutilization, but we have optimal utilization. Think Goldilocks and the 3 bears. That's what we're trying to do. And number 4, we're going to need some transition strategies. And I trust some of the questions will bring out some of the transition strategies that are probably more geared for telehealth technology. We talk about bundling. Telehealth technologies are probably, frankly, not the mainstream. It's not the first place you're going to start bundling. So a conclusion. What if we were to draw out this scenario of all of a sudden we opened up the spigot and we were providing fee-for-service utilization for telehealth monitoring, for telehealth technologies? What would happen? 4 things. Number 1, clearly telehealth monitoring volumes would increase. You would be monitored, your parents, your grandparents, your kids, your dog, your cat, your ferret. We would have lots of monitoring if all we did was pay for monitoring. And this would entirely be very positive for telehealth monitoring technologies. In fact, we would probably see the executives of telehealth monitoring companies soon lighting their cigars with $100 bills. Okay, number 2, chaos would ensue. As Dr. Putlitz points out, we really don't have the infrastructure yet for being able to provide systemic care. The technical standards of one company's methodology and architecture is not the same as another company's. Secondly, the workflow standards have not been worked out. I might think that monitoring is a good idea if I'm a doctor, but do the other providers who are part of the patient's care team? We haven't worked that out. And finally, the payers. Remember the lessons of disease management that we have learned, where when payers latched on to disease management, what we found is 14 different payers promoting 14 different ways of managing diabetes, sending out their protocols to the doctors. The doctors went crazy because they didn't want to deal with 14 different protocols, 14 different ways of reimbursing in an uncoordinated way. We'd have absolute chaos on our hands. So number 3, what would occur is we would have federal investigations of fraud and abuse and grand jury investigations. We would find that your ferrets and your dogs and your cats have set up illegal schemes where they are billing insurance companies and Medicare. And the final logical extension of this scenario is, as we evolve into the handbasket of hell, is that we would see on Oprah and Anderson Cooper telehealth executives being led away in handcuffs from the chaos that is being resulting. So I plead with you not to be deceived by the seductive vocal speeches of my colleague, and to ask you to vote for righteousness, the American way, and understand that we need to transition towards global and bundled payment models.
Thank you, Vince. I'm going to direct my first question to Vince and give him a limited time to answer, and then Dr. Putlitz will offer up his rebuttal. Access to care is a key issue in our country. Telehealth, telemedicine, and remote monitoring offer opportunities to address limited access to care. How does fee-for-service, as opposed to bundled reimbursement and other forms of reimbursement methods, impact access to care?
Access to care is the result that we would like to be able to provide. And if we were, again, to pay in an unfettered way for monitoring, what we would get is more monitoring. That doesn't equate to necessarily good care. It doesn't equate to quality care. And you might define that as access, but we need to look at other dimensions beyond pure access to care. The technology by itself, or the services, whether you think of telehealth monitoring as a service or a technology, by itself is not the solution. So what we need as part of the component of access is a system of care in which, again, we're not providing too much care under fee-for-service, we're not providing too little care. We want to build the optimum amount of care as our definition of access.
Dr. Putlitz.
Well, I feel sorry for him too, so. So, optimum level of care. Well, what is that? So, I mean, okay, we have capitation, and I was in this country in the 90s when capitation was really big, and so I was actually seeing how it worked or didn't work and so on. And then you have fee-for-service on the other side, But the fee-for-service the fee-for-service model I heard coming from Kuraitis here, this model actually is, that sounded like 50 years back, So is that really the fee-for-service that I have in mind when I advocate fee-for-service for adoption of telehealth and remote patient monitoring? No, I don't actually, because I think that, in the meantime, payers have become smarter. They can define criteria for what they're going to be paying. They can actually, in the field of telehealth and remote patient monitoring, they might be able to define standards. They might be able to define approaches that actually have worked and that have been demonstrated to be working, as opposed to just the next cool gadget that's coming out and might actually not add any value for care. So, I think that there are ways to actually put the fee-for-service scheme to work in this context without having all the negative effects, as opposed to a bundled payment that actually might activate the reflexes of capitation in the provider again, and that is actually what I'm concerned about, So that optimum level of care might be completely theoretical because, you can be incentivized either way. Is it for adoption? Is it for improvement of care, for care redesign, or is it essentially to save money and to really, instill a fight for the same dollar in a system where you have a bundled payment across, different providers, and in the end might not actually end up with that optimum care that we are all hoping to get, but probably will not get with bundled payments.
Thank you. Dr. Putlitz, this next question will begin with you. Bundled payments can make remote treatment attractive because they incentivize providers to render care outside high-cost facilities. Will this shift diminish or negatively affect the physician-patient relationship?
That's a very good and very relevant question. I actually don't think so. I think actually the physician-patient relationship will be strengthened with telehealth and remote patient monitoring. If you just take the data from the studies that have been done with the Bosch systems, you will actually see that way over 90% of patients say that they feel that they are closer connected to their healthcare professional, be it a nurse or be it a physician and so on. So I actually think this is a win-win situation here. I don't think that we are going to see a depersonalization of care or medicine through technology in general.
Vince, your rebuttal.
Well, let's spell out what it is Dr. Putlitz and I would very clearly agree on. The debate here is not about whether telehealth and remote technology is a good idea. We clearly agree that this type of technology has a tremendous role to play in improving patient care, in allowing for care to be provided in decentralized settings, in connecting the space in between doctor visits where patients traditionally fall off the radar screen. The debate is not about whether this technology is a good idea. The debate is about how we're going to pay for this. And when providers will be relieved with the pressure of having to maximize dollars in the context of this patient is here in front of me, that will be a very positive feature for patient-doctor relationships. And in fact, the patient will feel one of the complaints that patients have, referencing again the picture I painted to you of, I see my doctor, I've got heart failure, I got an appointment within 3 weeks later, I'm off the radar screen for 3 weeks. This technology has a potential to vastly improve the relationship because the patient will feel like they are still on the radar screen, part of the system, under the doctor's care, and if something goes wrong, that they know that they will be able to be in contact with and back into the health system in a moment's notice as appropriate.
Vince, I'm going to ask you to address this next question first. There are many proposed methodologies for payment reform: bundled payments, global payments, a blend of those reimbursement methodologies. Which of all of them will drive adoption of telemedicine, telehealth, and remote monitoring? A sub-question is, what are the unintended consequences for our healthcare system and our patients? And a second sub-question, which of the payment methodologies supports the adoption of telehealth, telemedicine, and remote monitoring?
Okay. Wow, that's a handful there. So, again, the framework of fee-for-service, we've got a risk of overutilization. Full capitation, we have a risk of underutilization. We're in this middle ground here. And effectively, the commonality among all these terms that are being tossed around, care coordination fees, patient-centered medical homes, global, partial capitation, they're all in this middle area of really trying to optimize care. Now, let me explain where telehealth is not at the top of this list, and I'll try and explain this from the vantage point of a hospital administrator. And I'll reference a particular book. If there's one resource that you would like to read to understand and really delve into the depth of the difference in the terminology that Joan is referring to, read a work called Transitioning to Accountable Care by Harold Miller. If you're a hospital administrator, you want to focus on conditions where you will start bundling, where you've got a large number of patients, where there's evidence of overutilization, where there is evidence that care and efficiencies can be gained through bundling. And the likely place you're going to start is somewhere around something that is highly standardizable, like orthopedic surgery. You're not going to start with chronic conditions. Your first goal as an administrator, then, you want to bond with your doctors. So the first layer of bundling is probably doctors and hospitals get together, and it might well be specialists. The next layer of bundling, and we will develop expertise in how to do bundled payments, infrastructure, and systems. Then you can start thinking about throwing into bundles different conditions, chronic conditions and conditions outside of the hospital. And we get into larger bundles where not only have we bundled the doctor and the hospital piece, but we put in the post-acute care piece. And that's where the use of telehealth technologies, I think, will really begin to thrive. But it's not the first area that we're likely to be bundling in. That is where, if the hospital is now responsible for and has to effectively provide a warranty that says if this patient is readmitted and that admission could have been avoided, and admittedly, we've got to work through a lot of data to really specify what that means, but it does change the financial incentives dramatically. And instead of the hospital having the financial incentive to not care once the patient is out the door, they will start to have to care for that patient for 30 days after. That's where, and we already see this in the Medicare regulations, they're going to be starting in 2012, we will see a dramatic rise in the adoption of telehealth technologies because the technology will be consistent with the economic incentives we're trying to provide of keeping people care optimally, not having them come back into the hospital. So example one is post-acute. A second one I'll just quickly point to, and then I'll let my colleague respond. Care coordination fees for primary care physicians. Real simple. You want the family physician, the internist to do care coordination, pay them. And we see a lot of experiments going on with this where $10, $20, $50 per patient per month is tagged on to an existing framework of fee-for-service payments as a way of providing reimbursement to the primary care physician to do exactly what it is that the payer wants, which is care coordination.
Dr. Putlitz.
Well, obviously this all sounds wonderful and very attractive, and I would be very happy to actually also believe in this, but I just can't really. I just cannot see how that would work. Think about the fragmented landscape I talked about in my opening statement. Think about the transparency you have about costs. Think about the amount of risk that a provider, a hospital, or a bundle of hospital and home care agencies and so on could actually take, the financial risk. Think about the difficult dialogue you would be having between non-clinicians and clinicians around what decisions are going to be made. I just think that in such a scenario, and I still think that this middle ground is somewhat theoretical because, it's either going to be incentivized this way or that way, so fee-for-service, more capitation-driven kind of incentivization patterns. I still think that actually would lead to reactivation of essentially a capitation behavior or behavior within a capitation scenario, which then in the end also might lead to a great variety in adoption of different technologies. A lot of them are going to be ineffective and might actually put patients at risk. I'm very concerned about that. If we want to get telehealth and remote patient monitoring to be successful, and if we want to look back in maybe 10 or 20 years from now and say, well, we did the right thing, telehealth and remote patient monitoring is really making a difference, then it has to be high quality, and that high quality needs to be paid for.
A note from the chair before I ask my next question. Vince was referring to a reimbursement rule change that Medicare will implement 11 months and 10 days from today. And that's a reimbursement rule change that will basically put hospitals at risk for readmission of patients within a certain diagnostic category. So when I went over our nomenclature at the beginning of the debate and talked about bundling, that's the method that Medicare uses almost completely with respect to inpatient reimbursement. And it's a game changer for hospitals. So,
may I respond
yes,
to
Vince.
my colleague? I think your point about this idea of optimal utilization being theoretical is worth exploring a little bit, and I would agree with you. And let me put this into context and why I gave the example of President Eisenhower. Were we crazy when we invented fee-for-service reimbursement? No. If you go back again to the kind of healthcare system that we had, where the model is you go in, you get fixed up, and you're out, and you probably don't have any contact with the healthcare system for a long time, fee-for-service is really not all that bad a way to do it. And again, in a 7-week hospital stay, you are effectively bundling all the care coordination, and there's not much of a risk of readmission if you've got a 7-week hospital stay. So yes, you're correct that this idea of, okay, we don't want to be over here with fee-for-service because we have overutilization, and we don't want to be over here with capitation because that's underutilization. There's this amorphous middle ground of somewhere in there is optimal utilization. You're right, we don't know where that is, but conceptually, we know that there is somewhere in the middle, and that's the system that we need to be building today. We don't have the evidence, and we also have to recognize that what is optimal is going to be very much dependent upon patient preferences. But that doesn't mean that it can't be realized. And so effectively, the system that the road that we are going down collectively is one of experimentation. And 10 years from now, do we know today what's better? Is it a care coordination fee, an episodic fee, a global fee? You know, there's a lot of different permutations there. Today we don't know, but what we're doing is clearly directionally correct in moving towards optimizing, even with the understanding that we may not be able specifically to define that.
Well, has bundled payment worked in the past? You know, so are there really a lot of examples that show that bundled payments have worked? Clearly, you know, bundled payments may work where you have control, where you actually can control the entire provision, where you have, you know, maybe a bundling between physicians and hospitals and so on, you know, but across the, so to speak, care continuum, you know, where you have less control, I'm not so sure we have a lot of evidence there. And so, as you say, it is experimentation. So if it is experimentation, then, you know, what percentage of telehealth and remote patient monitoring provision in this country would then be covered by bundled payments over time? It would probably be very small. And so going back to our question, you know, the future business model, the road to adoption, you know, an accelerated road to adoption, because we know that telehealth and remote patient monitoring is an intervention that has a high return on investment, you know. So if we really want to get this up speedy, would we do this with an experimental approach, or wouldn't we do this with a classical fee-for-service approach that is well managed, much better managed than in the past, is, you know, properly controlled, and can also adjust over time? I think we should really explore this as well. And I think this is going to be around in this healthcare provision system for quite a long time, and with a very large percentage of the overall telehealth and remote patient monitoring provision.
This will be my last question, and I want to point out the monitoring devices, I beg your pardon, the microphone devices right here in the middle of the room. Please feel free to make your way to those and ask questions when our two debaters have answered this next question. Historically, new technologies and new devices in healthcare have led to increased cost. Telemedicine, telehealth, and remote monitoring, according to many very wise industry observers, is revolutionary in that it actually offers a lowering of costs across the healthcare continuum. If telemedicine, telehealth, and remote monitoring succeed in lowering costs and lower reimbursement follows, how will innovation be funded? Dr. Putlitz, please go first.
Again, it's a very good question. Now, first of all, I think, you know, there's a lot of innovation in this field, and, you know, there are a lot of ideas out there. So, you know, I don't really think that that's a real problem. You know, I think that innovation is going to come, and it's here already, right? And you're right. This actually has a high return on investment, as demonstrated by a recent Health Affairs article that actually also used studied data that came from a demonstration that used the Bosch technology. And so, I mean, the industry and the excitement also in, you know, venture capital and so on is high around this. So you know, the innovation is happening, you know, and I don't think that's really dependent on the payment scheme, really. I think this is something that the payment schemes are important for adoption, but maybe less so for innovation per se.
Vince.
Earlier, I tried to share the perspective from the view of a hospital administrator, let me share it from how a medical officer at a health plan may look at this type of technology. A personal experience, I have, in working with consulting clients, it's a frequent request. People come and they've got a new technology, and they want the health plan to pay for it. And I remember sitting in the lobby of the health plan with the client, and the basic pitch is we're there to tell them that you ought to be paying for our technology. The medical director of the health plan is blinded. This is white noise. The person before us was there saying, we want you to pay for our tea leaf reading technology. It's going to make the world a much better place. And the person who is after us is saying, we want you to pay for our new genetic technology. And as a medical director of the health plan, you have an incredibly difficult time wading through all this stuff. And do you as a patient want that decision vested in the health plan medical director? What we want is that decision really vested in your provider. And that's where bundled global payments will excel, because it won't be a matter of the health plan having to decide to pay for tea leaf reading. It's a matter of your care provider adopting what we all intuitively believe and actually have lots of evidence for in the case of telehealth technologies. But again, if you put yourself in the shoes of the health plan director, everybody is saying that. It's white noise, you can't sift through it. Put the decision back between the patient and the doctor.
Can I just make a comment here? So that would mean that you actually put the health plan confusion back to the provider. So the provider is then confused about what to do. I mean, again, think about all the options you have for telehealth and remote patient monitoring. There are so many, who is able to tell what's going to work and what's not going to work, Look at technologies that actually have proven evidence behind them, as opposed to the ones that just state that they would have it, or the ones that actually don't have it, So actually putting this responsibility on a provider will create a large variety of models, a lot of them being very ineffective, Customer confusion, provider confusion. This is not going to work very well. People are going to try out a lot of things, and the collective wisdom of healthcare provision will actually suffer from this, and it will take a much longer time to get this helpful technology adopted.
Questions from the audience? Joe, you've got somebody who popped up ahead of you, so I'm going to use the prerogative of my office here to allow our audience member to go first. Go ahead, sir.
First of all, excellent debate. Enjoyed the discussion. And not surprisingly, because it was reimbursement oriented, most of the arguments that I heard articulated were supply side. What would, being that we all accept we want this technology to be diffused, what would be the way to best incentivize providers to do it? One of the themes that I've heard throughout the last day and a half has been the need to incentivize consumers to use it, beyond simply making it available, even in places like rural Alaska, having to actually pay consumers to engage the technology. So I guess the question is twofold. Is A, is this trend likely to continue that we'll need to incentivize consumers to do it? And then B, to this debate, are either one of those two methodologies more likely to lead to the ability to incentivize consumers to do so?
Dr. Putlitz, let's ask you to take first crack at that question.
Well, I think that's a very valid point. Obviously, telehealth and remote patient monitoring are only going to be effective and are going to work if you have patient engagement, And it's actually not that easy, as we all learn, to engage patients. The motivational patterns are very different. You can almost not generalize here. It's something that's very, 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 very individual, But I think over time, this industry is learning how to do this, and I think we have gone a long way. We've come a long way, actually, as an industry, to understand what really makes a difference here. So I would actually not say that the industry is completely supply orientated at this point. I think, you know, the demand orientation is at least in some industry players, and I would of course count Bosch in here. So it's very, very relevant, and is also clearly there.
Vince, your rebuttal.
I'll share an aha moment with a client, and I think I can disguise this a little bit. For me, it was a real revelation. The client was Intel, and the year was 2006, and we were doing back-of-the-envelope estimates of the number of patients that were actually under monitoring in the U.S. And we did numbers like, okay, we think the VA's got 20,000, and you know, there's over here 40,000 at home med and blah, blah. We came up with a number of about 150,000 people that were under various kinds of monitoring. And so I made the question, so your thinking is you would like to get this to the level where we're talking, what, 1 million, 5 million people? And the general manager at Intel said, no, we're thinking more like hundreds of millions or billions. This is where we would like to see this technology go. And if you think of remote monitoring technology as akin to the kind of technology that is with your cell phone where you buy it, today you can go down and start buying this kind of technology, and the price has gone from, it would have been $6,000 for a typical bedside unit perhaps 10 years ago, maybe $1,000 today. And when we get to this scale, it clearly will be a consumer technology, and it won't necessarily be limited, and we will have consumer adoption, and that will be a good thing.
A question from our audience.
Yes, given that claims data indicate that the incremental costs of behavioral health disorders, especially depression, increase the cost of care for chronic illnesses by between 50 to 100%, varying by condition, how do you see behavioral health being bundled in the healthcare system of the future?
Vince, will you please take that question?
Wow. You know, behavioral health as it's treated today is unfortunately, but realistically, largely carved out of the medical system. You know, we see separate benefits provided by behavioral health companies. And Steve, I know you and I think enough about this together. We would really all like to see the reintegration of behavioral health issues and medical issues, and not to have this artificial carving out. So I would say generally, to refer to your comment, that when we have integrated payment mechanisms, we are much more likely to get integrated care, and we will not have to put patients into artificially being either having reimbursement or not having reimbursement for the mental health issue. It's a broad question, but I'm going to reinterpret your question as is bundling good for behavioral health? And in the long run, I think the answer is yes, as we get better at it. In the short term, it's really problematic because it's not the area, again, where the initial bundling is likely to occur. So come back at me. I'm not sure I've answered your question.
No, that's fine. Do you see any, in your travels, do you see any organizations that are moving in that direction?
Frankly, I think my sense, and I don't have a world perspective on this, is where the discussions are occurring around bundling, care coordination fees, they're not occurring simultaneously around behavioral health conditions yet. That's a generalization, and this is probably where I would pull on the expertise of others in the room, but that's what I'm seeing. That's not where we're starting. Again, you start with a place where you got high volume, you got a strategic need to bond with your doctors. You start with orthopedic surgery. It's really concrete stuff where you can standardize it, not where in behavioral health, unfortunately, the human need is great, but the ability to diagnose and put the problem in perspective and then in turn to have a clearly well-evidenced and documented solution is not there. Those are areas where bundling becomes much more difficult.
Let me ask for our one rebuttal before we go to your
well,
next
not really
question.
rebuttal, just an additional comment there. I think behavioral health is going to be a key target and also element within the next wave of innovation in telehealth and remote patient monitoring. We've done a study at Dartmouth University that actually shows how powerful telehealth and remote patient monitoring can be. These are, early days for these kinds of interventions, but I think that's going to be very relevant in the future.
And a prerogative of the moderator, there is a waiver being sought. It's a combined waiver. It's one of the very first of its kind by several state Medicaid programs in the area of behavioral health. It's a focused waiver request on a nursing home population in the mental health care context. And it's a very interesting effort to address the subject matter of our last question. Yes, sir. Last question. We only have 5 minutes left, ladies and gentlemen.
Hello, Bosch, Johnson Diabetes Care. Very curious. We've talked to a lot of patients in Asia Pacific, and much more.
Speak up as much as you can.
We've spoken to a lot of patients in Asia Pacific, and there seems to be much more of a mentality to actually pay out of pocket. And so I'm very curious, from your perspective, will we ever get to that point in the United States if we build solutions that actually help patients, that they'll actually pay out of pocket for these solutions?
Before you, if I might,
Yes, Joe.
would you be willing to listen to just what his question is? And I want to throw out a question too, so people will hear the 3 questions and see how they respond.
Very good. Sir, you have been waiting patiently for your opportunity. Thank you, Joe.
Question brief. It's always nice to help an underdog. I think there's a very strong argument and a comment from a Deloitte study that 84% of people would rather be treated at home than even visit their doctor or go into the hospital. That's the opportunity. Without being too self-serving, I think I agree very strongly with Dr. Putlitz. Monitoring could actually add to costs if it's only afferent information coming back that has to be digested, whether it's EKG, whatever. And to my mind, a medication adherence device that can respond flexibly to the result of monitoring at home, that leads to care at home. That, to me, is the critical step. I think people will pay for it. They will have a preference for it, and fee-for-service would.
So my question, is this on?
Yep.
My question is similar to the first question that was asked, the question up here in his comment. I'm wondering whether any of you have seen any interest on the part of payers or providers or on the part of industrious vendors in this area to help develop new insurance products that, for example, might offer for me, the patient, if I'm monitored for whatever my condition might be, I don't have to pay a copay. And if I get myself within the range, I have a lower premium. On the other hand, if I am not monitored, I have a higher copay, and if I'm not in range, I have a higher premium. What about something like that to drive this industry? I think that might be similar to your question about the patient having some, skin in the game. Exactly.
Vince, I'm going to ask you to take on this Herculean task, try to encompass all these comments and questions in your answer.
So the nature of digital technologies is as counter to more traditional industrial technologies. As the industry grows and scales, prices go down. They go down dramatically. When HD TVs were introduced, they were $10,000. And now you can go and buy a 42-inch one. I think they're about $400 at Walmart. When remote monitoring technology was introduced 10 years ago, and I said the price was around $6,000 for some of the units that were out there, what I saw was clients doing very sophisticated return on analysis investments, trying to understand, is this a good thing to buy? Predictably, the price is already coming down, and it's going to come down to a level where this is a consumer technology. And that will dramatically increase the utilization. And to your point, Joe, again, what I'm trying to paint I think, broad but accurate picture of is we're in the middle of an experimentation process trying to find this area of optimal utilization. And we're throwing spaghetti against the wall, with different methodologies, hoping that some of it sticks. Your suggestion of co-pays based upon monitoring is a great one. Let's try it. Intuitively, it sounds good. Let's see if we can develop some evidence for it.
Doctor?
Well, let me repeat my pledge for fee-for-service, but not all the points. Just one. As you can see, in that fee-for-service scheme, the fee actually would not be that high. Prices are coming down. This is, a moderately low-cost intervention with a very high return on investment. And I guess, just, pleading to the audience again, we're going to have another show of hands shortly, I think. I would say, do you make up your mind. Do you want experimentation, and that will take a long time, or do you want rapid adoption of telehealth and remote patient monitoring? And, make your choice based on the answer to that question. Thanks.
1 minute summaries. Vince.
If you would like to see your dog and your cat and your ferret monitored, then by all means, let's have fee-for-service reimbursement for remote monitoring technologies. This really isn't complicated. It really is boiling down to a fairly simple issue. Which risks, how do we minimize the risk? We've got the risk of overutilization, and we have lots and lots of evidence. In the U.S., we spend 2 times per capita what every other developed country spends, and we get no better outcomes. The other risk is one of underutilization. We've learned that through early experiments with capitation. Okay, we know that being over here and reimbursing unfetteredly will provide for increased volumes of whatever it is you're reimbursing. That's not the right thing to do. What the right thing to do is to find the ways of defining and reaching optimal utilization with the full understanding that that's going to take a little bit of time to get there. But it's the right thing to do.
Dr. Putlitz.
Well, nothing to add to my previous 1 minute statement. I think we're ready.
So, our question. The business model for telehealth, telemedicine, and remote monitoring is not direct reimbursement. It's bundled and global payments. Agree or disagree? If you agree, please raise your hand. Well,
it's a little bit less, huh?
Vince. Thank you all very much for your attention and participation.
Thank you.